Hello. Okay, there's background noise. Shit, man. There's still background noise. Hello. Okay. I just noticed that removing charging helps to reduce the noise. I don't know how, but it helps. Okay. So this is OP GHAI, the book of pediatrics. And today we're going to study a new topic called convulsion, febrile convulsion, and meningitis. So we're going to study straight for 2 hours, in which we're going to take about we're going to take about 4 Pomodoro sessions, and one Pomodoro session is about it's going to be about 30 minutes. So let's start. So at first we're going to source a febrile convulsion. So okay, this is going to be difficult, I guess. What the hell? Okay, let's do it manually. So we're going to study about febrile convulsion. So febrile convulsion is common in case of children, especially in case of infants, toddlers, and so it is important topic. There are many other causes of convulsion, such as seizures, probably the epilepsies. So we need to know to differentiate between the febrile seizures and the non-febrile seizure. So it is very important to know about febrile convulsions. So we are here to do the real-time study from OP GHAI, and our channel's name is Study Medicine with me. So here you can study medicine with me. I'm going to study medicine, okay? And this is going to be, okay, we have already select the thumbnail. Now let's go and find the topic febrile convulsion. It comes with the F. So yeah, okay. So we're going to search about febrile convulsion. So fever of unknown origin, fever. Okay, there must be something else. Febrile convulsion right here. Okay, right here it is in the page number 556. There is also about the prophylaxis of the febrile convulsion and the treatment of febrile convulsion. So let's go to the 556 page number, which in this case might not be in that particular page number, even though we will try. So 556. So this is not a 556, it is 570 page number. So we're going to the 556 page number. So in case you are new, this is OP GHAI book of Pediatrics. So OP GHAI book of Pediatrics, and we're going to 556 page number. Okay, and we're going to study about febrile convulsion right now. There are many other topics that I need to cover, but febrile convulsion is one of them. So let's study. Okay, I'm going to just a minute. I think I need to fix this. Okay, never mind. Okay, first we do this. Okay, now we can do that. Now we're going to revamp this. How to? Okay, so now we got full page. So we were about to study febrile convulsion. So okay, there we go. So okay, now this is the topic febrile convulsion. Okay, it falls under which topic? We know this because probably CNS. Okay, yeah, in CNS febrile. Okay. Okay, let's talk about the febrile convulsion. Okay, febrile convulsion are the commonest provoked seizures affecting 3 to 5% of children. Okay, it affects 3 to 5% of children. They are defined as seizures during fever occurring between 6 months and 5 years. Okay, start from the 6 months and up to the 5 years. It's in the absence of infections. Okay, it's in the absence of infection of the central nervous system. Okay, it occurs in the absence of infection of central nervous system in a neurological normal child. Okay, the child is neurologically normal and there is no infection of CNS. Even though if there is any convulsion present, then it is febrile convulsion. So febrile seizures are frequently genetically determined. The convulsions are not related to the degree of temperatures, but are frequent if the temperature rises abruptly. Okay, so it is not associated with the temperature. For instance, if the child is having fever of about 41 degrees Celsius, the child might not have the febrile convulsion, but if the child is having fever of 38 and there is sudden increase of the temperature up to the 41 degrees Celsius, then there is high chances that the child might suffer from the febrile convulsion. Okay, the convulsions are not related to the degree of temperature, but are frequent if the temperature rises abruptly. Febrile convulsion may be simple, benign, or typical. Okay, it might be either simple and benign is the other name, and atypical and complex. Okay, simple or complex. Okay, let's look at the simple febrile convulsion. The seizure occurs within 24 hours of the onset of fever. Okay, 24 hours onset of fevers last less than 15 minutes and are usually single per febrile episode. Convulsions are generalized. There is no post-ictal neurological deficit. Okay, I doesn't know the term post-ictal, so I think I need to search it in Google. So I'm going to search post-ictal, P-O-S-T-I, ictal. So post-ictal is a state Altered state of consciousness is called postictal. Postictal is basically altered state of postictal is an alternate state of consciousness. So, so here we have convulsion are generalized. There is no postictal neurological defect. Not clear. Okay, so this one is simple febrile seizure. It occurs within 24 hours of onset of fevers and lasts less than 15 minutes. Okay, so it lasts less than 15 minutes and occurs within 24 hours. So 15 and 24 hours, 24 hours and 15 minutes. Okay, so let's talk about the atypical febrile seizures, which is also known as complex febrile seizure. Okay, atypical or complex febrile convulsions should be distinguished from the simple febrile convulsions. Okay, it should be distinguished. Okay, presence of family history of epilepsy, neurological development retardation, and atypical episode increases the reoccurrence risk of febrile seizures and subsequent epilepsy. Convulsion in developmentally challenged children may be precipitated by fever as the cerebral threshold for seizures is reduced with the elevation of the temperature. These are distinct from febrile convulsion which occurs in neurodevelopmentally normal child. Let's study this again. Atypical febrile seizures. Atypical or complex febrile convulsions should be distinguished from a simple febrile convulsions. Okay, it should be okay. So presence of family history of epilepsy, neurological development retardation, and atypical episodes increase the reoccurrence of febrile seizures. Okay, and subsequent epilepsy. So if there is any history of epilepsy in the family or any history of neurological retardation in family or any atypical episodes of seizures, then there is high chance of having recurrent seizures. The convulsions in developmentally challenged children may be precipitated by fever. So if the child is developmentally challenged, then it is precipitated by the fever as the cerebral threshold of a seizure is reduced with the elevation of temperature. Okay, let's study this. Convulsion in developmentally challenged children may be precipitated by fever as the cerebral threshold for seizure is reduced with the elevation of temperature. Okay, let's study this again. Convulsion in developmentally challenged children may be precipitated by fever as the cerebral threshold for seizure is reduced with the elevation of temperature. And these are distinct from febrile convulsions which occurs in neurodevelopmentally normal child. Okay, I'm processing it. Convulsion in developmentally challenged children may be precipitated by okay. If the child is already developmentally challenged, then it is high chance that the convulsion is precipitated by the fever and the cerebral threshold for seizures. Okay, because in that condition the cerebral threshold for the seizures is reduced. Therefore, simple fever could precipitate the seizures in case of children. Okay, these are distinct from febrile convulsions which occurs in neurodevelopmentally normal child. Okay, so what we studied till now is the febrile convulsion. It occurs up to 3 to 5 % of children. They are defined as seizures during the occurrence. Okay, and it occurs within the age group of 6 months to up to the 5 years. And the most important thing that we need to understand is that there is no infections of central nervous system in this case, and the child is neurological normal child. Okay. So if the child is neurologically abnormal, then there is high chances that a simple fever could trigger a seizure in case of neurologically abnormal child, because in that condition the febrile threshold is reduced. It's okay, and it could be and the seizures and febrile seizure can be divided into two categories: simple febrile convulsion and atypical febrile convulsion. Simple febrile convulsion is also known as benign febrile convulsions, and atypical is also known as complex febrile convulsion. And simple febrile convulsion is said to be simple febrile convulsion if the convulsion is called simple febrile convulsion if it occurs within 24 hours of occurrence of fevers and occurs for less than 15 minutes, and usually it is single, but multiple episodes can happen. So in that condition, it is called simple febrile convulsion, and this other something called as atypical febrile seizures. Okay, Okay. Okay, if there's any history of a family history of a epilepsy or neurological development retardation or typical episodes or increased reoccurrence of febrile seizures and subsequent epilepsy, it is called as atypical febrile seizures. So for the atypical febrile seizures, there should be a history of a epilepsy in case epilepsy or neurological developmental retardation or reoccurrent febrile attacks, sorry, neuro atypical episode of increased recurrence of recurrent febrile seizures attacks. Then the condition is called atypical febrile seizures. So febrile seizure, we know that it can be divided into two categories. So let's look at the differentiation from the meningitis. So it is very important to differentiate from the meningitis because in case of febrile seizure there is no infection of CNS, but in meningitis is basically an infection of a meninges, which is outermost covering of the central nervous system anyway. So it is actually infection of a central nervous system. I mean that meningitis is an infection of the central nervous system. So it is different from the febrile convulsions. So okay, how to differentiate from the meningitis? Infection of the central nervous system is such that meningitis or encephalitis are important cause of convulsions associated with fevers and can be easily confused with the simple febrile convulsions. Okay. Lumbar puncture should be performed in the first episode of febrile seizures in infants below 1 year who are not immunized with Hepatitis B and pneumococcal vaccine, or if the immunization status is not known and where the meningitis is suspected. Okay, in all the patients with febrile convulsion, a lumbar puncture is not required routinely. EEG and neuroimaging have role in febrile seizures. Okay, so we need to know the differentiation from of a febrile seizures from the meningitis. So if the child comes with a complaint of seizure along with a fever, so there is two possible possibilities. So number one is meningitis and other is febrile convulsion. So in order to differentiate, if it is not differentiate, or in order to separate that it is not meningitis, we need to do the lumbar puncture. We could do the lumbar puncture, or we could do the EEG or radiological imaging. EEG or radiological imaging. So lumbar puncture. Lumbar puncture is done in case of child who have been in case of child who have not been given Haemophilus influenzae B vaccine or Haemophilus influenzae B vaccine or pneumococcal vaccine, or both are vaccines, or whose vaccine status is not known. So in that condition, if the child is below 1 year and if their immunization status for Haemophilus influenzae B and pneumococcal vaccine is not known, and then they should be given lumbar puncture in order to differentiate between the meningitis or febrile seizures. So in lumbar puncture, what we can see? So in case of lumbar puncture, we could see that there is a there might be increase of a protein content. Okay, in case of bacterial meningitis, okay, and there might be increase of a increase of leukocytosis in a cerebrospinal fluid, protein content, and there might be decreasement of a glucose. So these are the factors that we could identify if there is a meningitis. But in case of febrile fever, these things doesn't occur or happen. So in that way, we could differentiate the febrile seizures. And another important way to differentiate the febrile seizure is EEG. Okay, so EEG. Okay, let's talk about the treatment. Febrile convulsions are managed by the prompt reduction of temperature with antibiotics or hydrotherapy. Febrile convulsions are managed by prompt reduction of temperature. Okay, antibiotics should be given. Okay, or hydrotherapy to comfort the patient. Maintenance of airways, breathing, and circulation should be ensured. In case of prolonged febrile seizures, intravenous access should be established to maintain the adequate hydration and to administer anticonvulsant medications. Possibility of meningitis should be excluded by a lumbar puncture if indicated. Injection of midazolam or diazepam is given to control the seizure. So in case of febrile seizures, so what is the drug that is given in case of febrile seizures? So it is midazolam or diazepam. how much it should be given? It should be given 0.2 to 0.3 milligram per kg per dose. Okay, midazolam or diazepam. It is important to midazolam or diazepam, and the amount given should be between 0.2 to 0.3 milligram. It's important, milligram per kg. So if it's 3 kilos child, this should be given. Okay, 0.6 to 1.2 gram of diazepam or midazolam. So the treatment. So let's go to the treatment once again. In order to treat the treatment, as first there must be a treatment of a fever. So in order to treat the fever, there must be given antibiotics, and hydrotherapy would be done. I don't know what does this hydrotherapy means, but it is something. It should be something. Hydrotherapy to comfort the patient. Okay, so if there's so the airway should be maintained, breathing and circulation should be ensured. Okay, so respiratory pathway should be observed carefully. Okay, so in case of prolonged febrile seizures, intravenous SS should be established to maintain adequate hydration. So if the patient is having prolonged seizures, which is basically atypical or complex seizures, the intravenous SS should be maintained in order to prevent the patient from the convulsions, dehydrations. So I just come to know that this thing is not right. Okay. Anyway, so we almost finished this febrile seizures. We studied about febrile seizures, then type of the febrile seizure, which was much easy, how to differentiate it from the meningitis, and about the treatment. It was easy as well. So once again, let's repeat what we need to give for the treatment. So the drug that we need to give for the treatment of a meningitis is the midazolam and the diazepam. Okay. So prophylaxis of febrile seizures. Febrile seizure prophylaxis. Prophylaxis may be continuous or intermittent. Intermittent prophylaxis of febrile convulsion is indicated if 3 or more febrile seizures in intermittent prophylaxis of febrile seizure convulsion is indicated if there is 3 or more febrile seizures in 6 months. If there is within 6 months, if there is more than 3 seizures, then the prophylaxis of febrile seizures should be indicated, or 6 or more in 1 year. Okay, febrile seizures lasting more than 15 minutes or requiring pharmaceutical therapy to control seizure. So what are the criteria for prophylaxis of febrile seizures? There are basically three criteria. Either it should be more than 3 times in 6 months, or it should be more than 6 times in 1 year, and it should last about more than 15, or either it should last more than 15 minutes. So in that condition, we could provide the prophylaxis of febrile seizures. So let's look at the type of the prophylaxis. So intermittent prophylaxis. Okay, intermittent prophylaxis is currently prescribed during the episode of the fevers. A drug that attains the drug. Is currently okay. Let's start again. Intermittent prophylaxis is currently prescribed during the episode of the fever. A drug that attains drug level quickly and prevents febrile convulsions should be used. What does this mean? So intermittent prophylaxis is currently prescribed during the episodes of the fever. A drug that attains drug levels quickly and prevent febrile convulsions should be used in this condition. Okay. So what are the drug that attains drug levels quickly and prevent febrile convulsions? Okay. Midazolam, is it? Or diazepam? I don't know. Oral clobazam is an effective prophylactic and is given for 3 days during the fever episodes. So the prophylaxis, okay. Antibiotics, hydrotherapy, and meticulous temperature recording should be advocated for all the patient. Domiciliary care is recommended, and I don't know what this domiciliary care means in case of intermittent prophylaxis. So once again, so intermittent prophylaxis is recommended in case of episodes of fevers, and in this case a special type of drug is given which attains its level quickly and prevent the seizures, and the drug is clobazolam, and along with the clobazolam, and it should be given for the 3 days during the fever episode. Okay, during the fever episodes, and along with it antibiotics and hydrotherapy can be given, and something else domiciliary care should be recommended. So we're going to look at the topic we call as domiciliary care. So I'm going to the Google. Domiciliary care. Okay. Domiciliary care. What is domiciliary? Provided people who still live in their own home but require additional support with activities including household tasks. Okay. This is kind of provided to elderly by qualified home care workers at seniors. Okay, I don't know. Basically, like okay, I think domiciliary care is mainly associated to the elders, but it's could be given to the child as well. If the child is mainly prone to the infections or disease. So okay, domiciliary care should be given in case of febrile seizures, multiple febrile seizures, if it occurs more than 3 times in 6 months or 6 times in 1 month for more than 15 minutes. So domiciliary care should be given, and in that condition a drug called as clobazolam should be given. So what is the dose of the clobazam, 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 clobazam should be given, and the dose is 0.7 to 1 milligram per kg, 0.7 to 1 milligram per kg. Okay, so let's suppose there is a 6 kg child, and then what amount of clobazolam should be given? So it should be about 6 milligram of clobazolam, because the range is in between 0.75 to 1, and I will consider 1. Why give less if you get more? So continuous prophylaxis. Okay, in continuous prophylaxis, so previously it was intermittent prophylaxis. Now we're talking about the continuous prophylaxis with the antibiotics. Okay, So the continuous prophylaxis with antibiotics drug is advocated in event of failure of intermittent therapy. Okay, if the intermittent therapy is given and it is failed, then anti-epileptic drugs should be given. In that case, recurrent atypical seizures in particular when parents are unable to promptly recognize the onset of fever. Only sodium, okay, uh, sodium valproate 10 to 20 milligram per kg per day or phenobarbital are effective for febrile seizures. Prophylaxis, carbamazepine and phenytoin are ineffective. The duration of therapy should be given 1 to 2 years or until 5 years of the age. Okay, so it be for 1 to 2 years or until 5 years of age, not more than that. Okay, so febrile seizure is we all study that febrile seizure is most common in case of 6 years to the 5 years of child, and if the if the intermittent prophylaxis fails, then we need to get the continuous prophylaxis, and in continuous prophylaxis we should give them anti-epileptic drugs, and the anti-epileptic drugs includes sodium valproate and phenobarbital, where the carbamazepine and phenytoin are ineffective, and the duration of therapy should be for the child of 1 to 2 years or until 5 years of child. Okay, so this was about the continuous therapy prophylaxis. We need to know the drugs. So clobazam for the intermittent prophylaxis, and for the continuous prophylaxis we need to give the sodium valproate and phenobarbital. So what the drug for the clobazam? The drug range for the clobazam was about 0.75 milligram to 1 milligram, whereas the drug dose for sodium valproate was over 10 to 20 milligram per kg per day, or sodium valproate or phenobarbital is for 3 to 5 milligram per kg per day. Okay, 10 to 20, 3 to 5 milligram per kg per day. These are important, these doses, because we are doctors and we would eventually find these cases, so we need to have a knowledge. So let's study about the prognosis of a febrile seizure. Recurrence risk of febrile convulsions varies from 30 to 50%. Risk factor that can predict the reoccurrence of simple and complex febrile seizures are early age of onset. Okay, epilepsy or fevers in first degree relatives. Okay, if there's epilepsy or fevers in first degree relatives, then there is high chances that the patient might get epilepsy. The febrile seizures. Okay. So what should we do in history? We should ask for any history of epilepsy, because it might be related to the febrile convulsions. And frequent fevers and low temperature are the onset of a febrile seizures. Over 1 to 2% of children with simple febrile convulsions. Epilepsy or fevers in first degree relatives. Okay, frequent fevers and low temperature at the onset of febrile seizures. Over 1 to 2% of children with simple febrile convulsions, and up to man. Okay. Over 1 to 2% of children with simple febrile convulsion. Okay. Frequent fevers and low temperature at the onset of the febrile seizures. About 1 to 2% of children with simple febrile convulsion and up to 5% of those with recurrent complex seizures are likely to develop epilepsy. So 1 to 2% of the child who had febrile seizures, simple febrile seizures, and 5% of those with complex febrile seizures develops epilepsy at older age. So what we could predict from this is that we should prevent febrile convulsion in case of children. Parents of the child should be reassured that the risk of epilepsy after simple febrile seizures is not significantly greater than the general public. Okay, so if the patients, if the child comes with a febrile seizure, the patient might get worried about the episodes of epilepsy in case of children, they might think that their children will have epilepsy, which is a difficult disease, which is very hard to handle. But we need to ensure but the rate is very less, about 1 to 2% in case of simple, and only 5% or in case of complex. Even in case of complex febrile seizure, there is just a 5% of chances. So we need to be able to convince the parent that there is very low risk chance of the child to have epilepsy. Okay, so the risk of developing epilepsy is higher if the seizures are atypical. Okay, if the seizure is atypical, uh, which is basically more than 15 minutes, and of course. So what is typical and not typical? Typical febrile seizures is seizures which occurs within the 24 hours and occurs for more than 15 minutes. So what typical seizures are, the thing other than that, okay? Which comes multiple times and occurs more than 6 minutes, okay? So electroencephalogram is persistently abnormal, okay? So the risk of developing epilepsy is more common if the seizure is atypical, and EEG is abnormal, and if the child has abnormal neurological, okay, if the child has abnormal neurological development or family history of epilepsy, a complex partial seizures may manifest after several years of prolonged atypical febrile convulsions. Okay, here we finish the febrile seizures. It was very short topic, but we finished. Okay, so let's revise it just for God's sake. So febrile convulsion, it occurs up to about 3 to 5% of child, and it occurs within the age group of 6 months to 5 months, and 6 months to 5 months, and it can be divided into two types: simple or benign convulsions, or typical or complex convulsions. The simple convulsion occurs within the 24 hours, and it occurs for less than 15 minutes, and it is generally only one episode, whereas the atypical seizures is more common in case of child with the relative who have a neurological development, epilepsy, or history of febrile seizures, and it is basically occurs for more than 15 minutes, and in a case of atypical fever there might be a case of more episodes, and it might occurs for a longer time, and okay. And so how to differentiate it from the meningitis? In order to differentiate from the meningitis, the febrile convulsions should be so the child who have not been vaccinated should be given lumbar puncture, and if not, they should be given electroencephalogram. So treatment, what are the treatments? So treatment, we could give the metazolam or diazepam. The dose is about, I think, 0.2 to 1, I guess. Okay, it is 0.2 to 0.3. I was not saying this. Metazolam or diazepam 0.2 to 0.3. Okay. In case of, so let's talk about the febrile seizures prophylaxis. So febrile seizure prophylaxis should be given to those child who had more than 6 episodes of febrile seizures in 1 year, or more than 3 episodes of febrile seizure in 6 months, or the febrile seizure lasting more than 15 minutes. So there are two types of prophylaxis could be given. The number one is intermittent prophylaxis. So intermittent prophylaxis, the drug which attains attains levels quickly, and prevents febrile convulsion should be given, and that drug is clobazam, I guess. Clobazam, yeah. The drug is clobazam, and the dose given should be is in between 0.75 to 1 milligram, and in continuous prophylaxis, anti-epileptic drugs should be given, and it is given if the intermittent therapy is not working, and the drug such as anti-epileptic drugs is given in this case, and the drug is sodium valproate or what was that, sodium valproate, which is about 10 to 20 milligram per kg per day, I guess. Yeah. And phenobarbital, I was forgetting this phenobarbital, important. No, which is about 3 to 5 milligram per kg per day should be given, and carbamazepine and phenytoin are ineffective in this case, and the duration of therapy should be in between should be for 1 to 2 years. Okay. So I just forgot to mention that. Okay, I misunderstood this sentence. So it should not be more than 2 years or less than 1 years continuous therapy, and it must not last more than if the child is 6 years. Child grows older. Okay. So what are the prognosis? Okay. So risk factor is very less in case of febrile seizures to attain epilepsy. Only 1 to 2% of a child with a typical seizures or 5% of the child with atypical seizures uh, are able to get this epilepsy. So we need to make the patient's parent patient parent assure that their child has very less chances of having epilepsy, and and the other thing to note, other important thing to note in this case is in case of in prognosis is that if the patient or the child is uh, having atypical seizures, which is which is shown abnormal even in case of electroencephalogram or EEG, and if the patient has abnormal neurological development, then there is high chances that the child could get epilepsy. So in case of history, it is very important to note if the patient had EEG in the past and what was the result of the EEG, or it is very important to note the development of the child in order to predict the epilepsy reoccurrent in the near futures. So, so epilepsy, I don't think I should read epilepsy because what the hell? There are a lot of drugs for the epilepsy. Oh my god, look at this. Oh my god. Different type of seizures, different type of drugs. Okay, their duration. Oh my god. Prognosis. Oh, this is not a simple term, you know. I guess I will study meningitis. This meningitis should be near there somewhere. Metazolam, clobazam, metazolam or what? Damn. Imaging, neuroimaging. So these are the terms that are used in case of CNS, lumbar punctures, level examinations, motor examination, physical examinations. So what are importance of physical examination in case of CNS? Okay, let's see. Infection is a crucial part of neurological examination. Observe the posture. Okay, we need to observe the posture, quality and symmetry of spontaneous movement. Behaviors, apathy, interest in surrounding, hyperkinesis, involuntary movements such as tremors, uh, athiotosis, chorea, myoclonus, and convulsions could be seen from the physical examination. So cranial examinations will be done as well. For instance, for oculomotor knob examination, we could use soap if the patient gets the smell or not. And for the optic nerve, there are various tests. Okay, let's study this. Response to light and stimulus and pupillary reflexes shows integrity of second and third cranial nerve. Okay, response to light and pupillary reflexes shows the integrity of second. Okay, this optic and oculomotor nerve. They mean okay. Ophthalmoplasia and paralytic squint indicate involvement of a third cranial nerve. Ophthalmoplasia. Okay, down and out movement of the affected eye indicates fourth cranial nerve. Trigeminal nerve. It means okay. Down and outward movement of the eye, down and outward movement. What does this mean? So let's suppose this is an eye and the eyeball is down and outward. Okay, the eyeball is situated right here. Then it is high chance that a person is suffering from the defect of. Sorry, I need to draw this figure again. This is not that good. So let's suppose this is an eye, and while examination of eye, the eyeball is down and outward. So this is eyeball. So in this case, we could know that there is defect in trigeminal nerve, which is fourth trigeminal nerve, which is actually a fourth cranial nerve, which is fourth cranial nerve. Just, just now palsy diagnosed. Okay. Ophthalmoplegia in case of light reflex in case of second cranial nerve, pupillary reflexes third cranial nerve, and down and outer movement of the indicate the fourth cranial nerve involvement. Fifth nerve integrity can be checked by conjunctival or corneal reflex. Sixth nerve palsy is diagnosed by a convergent paralytic squint. Okay, what the hell? Maybe false localizing signs, facial asymmetry or loss of natural labial fold on ipsilateral side. Pulling of the angle of the mouth and contralateral side and drooling of the saliva indicates a paralysis of seventh cranial nerve. Drooling of the saliva and pulling of the angle of mouth to contralateral side. Okay, I need to see the figure for this. The integrated cochlear division of the eighth nerve is checked by auditory tracking. Ninth and tenth integrity is determined by gag reflex and plateal movements. If the child can stroke his shoulders and turn his neck from side to side, 11th nerve is intact. Neck from side to side, 11th nerve, obviously. I will take 5 minutes break. The child can stroke his shoulders and turn his neck from side to side, 11th nerve is intact. Hello, I'm back. So I think we should also study our EEG because it is one of the most important diagnostic tool in case of CNS. Hello, I'm back. So I think we should also study our okay. So there was some audio problem which I solved right now. So let's go to the topic. So going to the topic, we are about to study something called as electroencephalogram. So electroencephalogram is commonly employed test. Okay, electric activity is recorded by placing a set of electrodes on the scalp. Okay, electrodes is kept in the scalp in a specific arrangement. So there is special arrangement. Okay, recorded rhythms are evaluated by their rate, Haz, amplitude, symmetry, synchrony, morphology. Okay, this is difficult. The various rhythms include beta rhythm at 14 to 20 Haz. Okay, beta rhythms, alpha rhythms, which is in between 8 to 13 Hz, and theta rhythm, which is about 4 to 7 Hz. So let's okay, beta is maximum, which is about 40 to 20 Hz, and 8 to 13 Hz there is something called as alpha, and theta is in between 4 to 7. So least is theta, which is about 4 to 7 Hz, and then there is alpha, which is in between 8 to 13, and 14 to 17 there is beta wave. And there's also called delta wave, which is actually 1 to 3 Hz. Delta, theta, alpha and beta. Delta 1 to 3, theta 4 to 7. Okay, activity faster than beta can be an artifact from the scalp muscles. Figure 18.1 depicts a normal EEG record. Let's look at the figure of 18.1. So what can we see in this? So are we able to understand or get any alpha, beta, theta and delta? Delta, theta, alpha and beta waves? No, we are not able to differentiate. So this is, just remember that this is normal EEG in a 5 years old child. Note normal posterior dominant alpha background activity. Damn, I'm not able to see a single thing. How could we understand? So it is something called as abnormal EEG. Look at this. Look at this line. Oh my god, yeah. They are overlapping each other. It must be abnormal. Okay, abnormal EEG in a 4-month-old showing abnormal slow chaotic background with multifocal spike suggestive of hypsarrhythmia. Okay, what does that mean? Hypsarrhythmia is new term. So what are the indications? Or let's look at the indication of EEG. EEG is useful in classifying, supporting, and confirming the diagnosis of epilepsy. So for the diagnosis of epilepsy, it is very important thing is EEG. And epilepsy syndrome, okay, and or also in the epilepsy syndrome. Okay, it distinguishes between the seizures and non-seizure states. Example: fainting spells, hypoxic episode, and breath holding. Okay. It also helps to differentiating the fainting spells, hypoxic episodes, or breath holding spells. The breath holding spells are common in case of child if they are too much greedy, they want something, but they want something anyway. They would cry till their breath goes out, and they will have a seizure. So in that condition, to differentiate it from the epilepsy, we could do the easy, but other factors are other factors are important as well in this case. Not easy anyway. Hypoxic episodes. Okay, hypoxic. Okay, in case of less amount of oxygen, there might be condition of epilepsy or seizures. Okay, so in order to differentiate that as well from the epilepsy, we could perform EEG and fainting spells. Okay, EEG is especially helpful for diagnosis of absence of attacks, myoclonic epilepsies, non-convulsive status, epilepsy syndromes, SSPE, and herpes encephalitis. EEG is not indicated in typical febrile convulsions. It is not indicated in typical febrile convulsions. You getting it? It is not indicated in typical febrile convulsion. Okay, abnormalities. The common abnormalities of background includes slow, abnormal, or asymmetric rhythms. This may be generalized, localized, and lateralized to one side, and thus helps to localize anatomic lesions. Okay, I need to understand this as well. Again, abnormalities. This common abnormalities of background includes slow, abnormal, or asymmetric rhythms. Okay, these may be generalized, localized, or lateralized to one side. Okay, these might be localized or generalized to one side, which helps to localize the anatomical lesions. So we could determine the anatomical lesions through the EEG as well, if they are unsymmetric in one of the sides. Okay. In addition, spikes, sharp waves, polyspikes, or hyperstereotypia may be seen in certain epilepsy syndromes. Spikes are the transient discharge that stand out from the background. Last less than is to last less than 70 milliseconds and often accompanied by a slow wave. When spike occurs very closely, they are called polyspikes. Sharp waves have a duration of 70 to 20 milliseconds and are less pointed. A 3 per second spike and wave discharge is observed in typical absence attacks. Brief bursts of polyspikes are common in myoclonic epilepsies. In benign focal epilepsy of childhood, clusters of high amplitude spikes, wave complexes are seen in Rolandic areas. Okay, high voltage. Okay, damn it. A 3 per second spikes and wave discharge is observed in typical absence attacks. Brief bursts of polyspikes are common in myoclonic epilepsies. In benign focal epilepsy of childhood, clusters of high amplitude spikes wave complexes are seen in Rolandic areas. High voltage, less than 100 microvolts, generalized chaotic source waves, and multifocal spikes are common in infantile spasm. Subacute sclerosing SSPE. I have heard this term. Subacute sclerosing panencephalitis is characterized by the periodic epileptiform discharge recurring at similar intervals. Periodic epileptiform discharge recurring at similar intervals. Epileptiform discharges recurring at a similar periodic at the similar intervals throughout the record. The discharges are similar in morphology and amplitude and often superimposable. Herpes encephalitis may be associated with the periodic lateralized slow waves and high voltage complexes. Sclerosing subacute sclerosing panencephalitis is a condition in which there is spikes are periodic. Spikes should last less than 70 milliseconds. Okay. Polyspikes are seen in myoclonic epilepsies. In case of myoclonic epilepsy, there is the presence of polyspikes, 3 per second spikes. Okay, within 1 second there are more than 3 spikes, and then spikes and wave discharge are observed in typical absence attacks. 18.3 typical absence attacks. Damn, I don't know what does that mean. So in case of typical absence attack, there is a 3 spikes, 3 more in 1 second, within 1 second. These are 3 spikes. This is within 1 second. 3 spikes within 1 second, and in case of typical absence attacks, Brief burst of polycyclic common in myoclonic epilepsy. Okay, in case of myoclonic epilepsy, there is brief burst of typical epilepsy. Okay. These are not that important, I guess. Video of EEG and EEG to know the using surgical foci of epilepsy, and in management of intractable epilepsies. Magnetoencephalography records the magnetic field generated instead of electrical potential and can localize the focus three-dimensionally. CT scan is also important. Okay, even the MRI is important. Delineation, gray-white matter distinctions, detection of myelination, congenital abnormalities, vascular anomalies, migration defects with a far greater diagnostic results in CT. The midline sutures, the posterior fossa, the brainstem structures can be visualized as well. Sagittal and coronal views permit a volume evaluation of CN structures. Some degenerative disorders can be picked up early by the MRI. MRI is also particularly used in patients with intractable epilepsy, agitation, and anatomical localizations of the lesions. Newer MR techniques, MR that identifies metabolites like metabolites. Okay, MR spectroscopy that identifies metabolites like NAA, choline, lactate in specific molecules of brains is useful for diagnosis of metabolic disorders, CT lesions, and tumors, and is being increasingly used as an investigation tool. Functional scans like positron emission tomography helps to demonstrate the perfusions, oxygen, and glucose uptake in different part of the brain, like cerebrum. So PET scan, okay, PET not a scan. Positron emission technology helps to determine the amount of glucose or oxygen taken up by the brain. Oh my God, positron emission technology. Cerebrum, thalamus, and basal ganglia. These scans have utility in identifying surgically resectable intractable epilepsies, cerebral tumors, and head injuries. PET scan can be modified to assess the cerebral blood volumes and cerebral blood flows, cerebral glucose metabolism. These have been used as research tools for assessing brain development, speech, and vision dysfunction. PET is extremely useful for localizing of anatomic focus in pre-surgical workup intractable epilepsy. About 5% children experience convulsions during the first 5 years of life. Motor movements, so we are studying seizures. Seizures, convulsions, fits are caused by abnormal electrical discharge from the brain and resulting in the abnormal involuntary paroxysmal motor, sensory, autonomic, or sensorial activity. About 5% of children experience convulsions during the first 5 years of the child. Motor movement consists of a tonic and clonic component. Tonic and clonic components are the most commonly observed phenomena except in the newborn period. Several times a child may present with a condition that can mimic or be misinterpreted as a seizures. This condition includes convulsive syncope or with or without cardiac dysarrhythmia, disordered posturing, psychogenetic activity, dystonia, migraine. Seizures should be differentiated from this condition as a misdiagnosis can have significant implications. Neonatal seizures often present with the twitching of the limbs, fluttering of the eyelids, shocking movements, and conjugate deviation of the eyes. Conjugate deviation of eyes. This should be distinguished from the jitteriness, tremors, startle response or to stimuli, sudden jerks, or awakening and hungry charge. Common causes of convulsion are better classified according to age at onset. Typically, it will go on. The twitching of the limbs. Okay, this twitching of the limbs, fluttering of the eyelids, shocking movements, and conjugate deviation of the eye. This conjugate deviation of the eye, there is movement of a hand as well, which is twitching, and fluttering of the eyelid as well, shocking movements. I don't know what is shocking movement. Oh my God. So So I can see that you guys are having problem because of the background noise, and that background noise is because I'm charging my laptop. Okay, it happens. I don't know what to do. I don't know how this sound comes when I charge. Probably because it's defecting this battery. Hello. Okay. So the time that we have been studying is about okay, 1 hour 11 minutes only. Okay, that is this time. Considering the backward noise is coming from this is too much. Even though approach to start with conversions. Good discussion. Okay, oh my god. So even though I'm having audio problem, you guys could hang out. Okay, let's study the approach to a child with convulsions. A good description of seizure includes mode of onset, detail of aura, type of seizures, automatism. Should be okay. Automatism is to be able abnormality and participation should be obtained. An accurate seizures description is more informative than detailed neurological examinations. It is very okay. Seizure description is very important than examination, even though investigations. Perinatal development, family history, seizure self-determine the cause. The child should be examined for evidence of raised intracranial tensions, degenerative metabolic or congenital disorders. Degenerative metabolic or congenital disorders. So we need to examine for the increased in intracranial pressure, and we need to examine for the metabolic changes and congenital disorders. So causes of convulsion, there are many causes of convulsion. So this could be important. Oh my god, there are a lot. This figure is important. Okay, So considering the birth, there might be the birth asphyxia, difficult after the labor. There might be intraventricular, intracerebral hemorrhage. Okay, this pyridoxine dependency. Okay, hypoglycemia, hypoglycemia, hypocalcemia, inborn errors of metabolism, maternal withdrawal of medications, injection of a local anesthetic into the fetal scalp during the paracervical block given to the mother. Okay, so there are a lot of conditions that causes convulsion. So let's go through it once again. In case of neonates, okay, neonates is a child which is 0 to 7 days, okay, old, 0 to 7 days old. So there might be due to both asphyxia, one of the most important one, I guess, difficult obstructive labor or difficult obstructive labor, or it might be due to interventricular or interventricular or intercerebral hemorrhage, or it might be due to the pyridoxine dependency, hypoglycemia, hypocalcemia also causes this disease. Okay, metabolic disorders, inborn metabolic disorders, pyridoxine dependency, we have already studied about that. Maternal withdrawal of medications, okay, and it might be due to the accidental injection of a local anesthetic into the fetal scalp while giving it to the mother, while giving the paracervical block to the mother. So these all are the causes of a convulsion in case of neonates or newborn child. So let's talk about the neonatal period from early. Okay, this was of the early neonatal period. So I'm closing my eye and I'm trying to guess the causes. So number one cause is both asphyxia or abnormal labor, and number two cause is intraventricular intercerebral hemorrhage. Number three cause was hypoglycemia and hypocalcemia, and number four cause was pyroxine dependency, I guess. And it might be also due to the withdrawal of medication, and one of the accidental causes due to the ingestion of a local anesthetic to the fetal scalp while giving it to the paracervical area of the mother. So this was the cause of a convulsion in case of early neonatal period. Let's talk about the cause of the convulsion in neonatal period, which is about 7 to 30 days. So there is something called transient metabolic hypocalcemia. Okay, it might be the hypocalcemia, hypomagnesemia, hypoglycemia as well, and dyselectrolectemia, what do you mean dyselectrolytemia? Generally, this term comes with something painful. For example, dyspareunia means painful sexual activities. Dyspnea means painful breathing. Dysphagia means painful swallowing. So dyselectrolytemia, what does this mean? Probably means decrease in electrolytes. Okay, hypomagnesia, hypocalcemia, and dyselectrolytemia. So let's talk about it might be also increasing developmental malformation, and convulsion is common in case of infections such as meningitis, obviously, septicemia, tetanus neonatorum, intrauterine infections. It is common in case of metabolic errors such as phenylketonuria, maple syrup urine disease, and galactosemia uritis. So phenylketonuria is common disease, and maple syrup disease is the disease that you have studied and forgot as well. Maple syrup disease and phenylketonuria is one of the most important causes. Galactosemia uritis cycle disorder. There is hypocalcemia and hypomagnesia in both early neonates and middle neonate, I guess, and neonatal periods. There was infection. There was both especially in case of early neonatal period, but in case of neonatal period, which is about 7 days to 30 days, there is a chances of meningitis, septicemia, and tetanus neonatorum. Tetanus neonatorum is caused mainly due to the tool that is used to cut the umbilical cord. For an instance, if there is any child which is home delivered, then and comes with a complaint of convulsions and fevers, then it is highly likely to be the tetanus neonatorum, because because of the instrument that they used for cutting the umbilical cord might be infected with the Clostridium tetani bacteria that ultimately result in this tetanus neonatal conditions. So intrauterine infection also might cause this, and other metabolic disorders such as phenylketonuria and maple syrup disease is one of the important cause in case of neonatal convulsions. So beyond the neonatal period, okay, there are a lot of things. For example, simple febrile convulsions. Okay, it is important to know that febrile convulsions cannot occur in neonates because it is the disease that occurs from the age of 6 months to the 5 years old. 6 months to the 5 years old. So it is important to know this. So febrile convulsions doesn't occur in case of neonates and early neonates. Okay. So simple febrile convulsion is common. Beyond the neonates, okay, epilepsy syndrome is common. Infections of the bacterial meningitis, obviously. Intrauterine infections, atypical meningitis, encephalitis, cerebral malaria, Reye syndromes are important. Metabolic disease such as phenylketonuria was there. Fetal and maple syrup disease was there in case of early neonatal period, but in case of beyond the neonatal period, there is other metabolic causes such as dyselectrolytemia, hypocalcemia, hypomagnesemia. So hypocalcemia and hypomagnesemia were in all cases. So if the child comes with the dyslipidemia, there might be a high chance that they might be suffering from the deficiency of calcium and magnesium. That might be a reason why the mother is called to have space occupying lesions, neoplasm, preynapsis, vascular internal thrombosis, miscellaneous hypertension, encephalocecal growth, drug drugs can cause also phenothiazide, salicylates, phenytoin, etc. So we studied about the causes of convulsions. Epilepsy is a very important topic which we should study, but I'm not been able to study this. I will study it tomorrow, I guess, but I don't think I will study this because it is not that important. It is important, but it is not that important. What to say? Management is not important, I guess. Coma is something else. Coma as well. Glasgow coma scale. Okay. I just don't know Glasgow coma scale. So what is this? This is the name that this topic is. Yep. Meningitis is an important topic. So this was all about. So guys, this was all about today's stream. It was not that long, but it was about an hour or more. So this was all. Goodbye. Have a good day, everyone. I'll be from now on. I'll do this regular, and this is going to be more than 1 hour from now on. So let's hope best for me. And I'll be continuing the stream. Thank you. Please subscribe the channel. Please subscribe the channel. I need this. So guys, bye.